Good morning, everyone. Thank you for attending the KHI eHealth Summit and joining us for our keynote speakers. All video and audio have been disabled, but if you have any questions, please place them in the chat box and we will answer them at the end of the session if there's time. I'd like to introduce Kevin Polari from Deloitte, who will introduce today's keynote speaker.
Good morning, everybody. I'm Kevin Polari, and I lead our Deloitte Kentucky practice. Deloitte Consulting is proud to be the diamond sponsor of the 2020 Virtual eHealth Summit. We've been committed to serving the Commonwealth for over 60 years, and of those 60 years, 2020 might be the most challenging. Through our close collaboration and partnership with KHI, the Cabinet of Health and Family Services, and the Department of Public Health, we have collectively been able to produce a rapid and comprehensive response to COVID-19. A few examples: we built and deployed an initial contact tracking and tracing solution in about 4 weeks. Now, we've incorporated several new capabilities for KHI, such as integration with many COVID test labs very rapidly, electronic case reporting, and COVID-19 event notifications. So it's my great pleasure to introduce our keynote speaker and to say a few words. Dr. Stephen Stack, our Commissioner for the Department of Public Health, has frankly been a real hero during this crisis. He was appointed Commissioner in February 2020 and surely had no idea what he's getting himself into. He's a board-certified emergency physician with more than 20 years of clinical practice and emergency department management experience. Incredibly impressive. In 2006, he was the first board-certified emergency physician ever elected to the American Medical Association Board of Trustees. And in 2015, he served as the youngest president of the AMA. He has extensive experience in healthcare policy at federal, state, and local levels. And he's also had significant engagements around health IT, including HIEs, while serving particularly as the AMA president. He graduated magna cum laude from the College of Holy Cross, medical education from The Ohio State University, his MBA at the University of Tennessee Haslam College, where he presently also serves as an adjunct professor for health policy and advocacy. Now, lastly, he's been a real pleasure to work with, and we Kentuckians are just truly, truly lucky to have Dr. Stack. So with that, I give you our keynote speaker. Thank you.
Well, hi, Kevin. Thank you very much, and thank you for the opportunity to be here today with all of you. I asked what was most desired for me to speak about today. And so some of the suggestions that were given to me were about the importance of health information technology, the fragility of technology and public health in general, public health information technology infrastructure. And then, of course, I could talk about the COVID-19 pandemic as much or as little as desired. And obviously, it'd be nice to talk about it as little as desired, more than as much as desired, given how much time we all have spent with our lives being altered by it. And certainly my life in participating in the emergency planning of it, it certainly consumes much of my waking hours of thinking. So let me give you a little perspective here in the context of this kind of meeting, how I see health IT and health information exchange and what my background is. And I don't need any persuasion about the importance of this. So as an emergency physician for more than 20 years, I worked in an environment that I frequently describe as fast-paced, information poor, where we had to make high-stakes decisions with incomplete information on a regular basis and still be held very much accountable for the outcomes of our actions. And so in that environment, it was very important to try to see, are there ways we can get the right information to the right people at the right time? And it remains a challenge. I remember when I started my career, the days of having patients come in with chronic medical problems and asking for their prior records, and someone literally went to a medical records room and would bring up a pile of papers that we would flip through and sort through, and that's how we got information. Now, that doesn't happen hardly at all anymore in any hospitals in the country. Now it's all digitized in electronic health records for the most part, and that has good and bad with it. One of the challenges has been, well, we eliminated silos of information clinically in paper. We recreated silos of information electronically, and I think it was underestimated by many, or it was at least not given the attention of seriousness it deserved, just how hard it was, and in some instances remains, for clinicians to retool the entire way their brain processes, organizes, acquires, and deploys information. It was one of the most distressing cognitive days I had in my entire medical career. Was the day that we went live with an electronic health record at my hospital, because in my head I could run an emergency department with 20 plus rooms, and I had an organization system. I knew where people were in the room, where they were in the process, the cadence at which things occurred. And one day we were there the normal way, which was checking boxes on papers and handing it to unit clerks and using paper charts to track information. And the next day it was all behind a computer screen somewhere. It was electrons somewhere else. And you had to go and find out how to access that information again and retrieve it. And it was I seriously mean one of the most distressing days of my professional life, because you had patients who had needs for things and I had needs for information. And it was all behind that screen somewhere in a computer somewhere, and you couldn't find it, you couldn't get to it. Now, we've come a long way, and of course, some of this is just cultural change. People have to learn a new process, a new routine, a new cadence. And the younger folks who come into practice will have never known the old paper world that I grew up in. They'll only know the digital electronic world that we have, and therefore not have to make that transition. They only know what they began with. So that situation will resolve itself over time, but nonetheless, we have a great opportunity to really build from where we are now and make big improvements going forward. And so in my prior professional journey, as Kevin said, I was a trustee for the American Medical Association. I had the wonderful privilege and opportunity to be one of our principal leaders at the American Medical Association for Health Information Technology. And so my involvement began around 2007, 2008, which was right before HITECH was passed. And HITECH was the part of the American Reinvestment and Recovery Act of 2009, where they were trying to stimulate the economy any way they could. And one of the ways they chose to do it was to put up to close to $40 billion into investing in health information technology nationwide to try to get all hospitals and medical offices to transition to electronic health records. And I remember that very clearly. So I was there at the very beginning. I was on almost 10 federal advisory committees with the Office of the National Coordinator for Health IT. I was there at the very beginning when people were essentially whiteboarding what would meaningful use for electronic health records look like through a phase 1, phase 2, phase 3, or stages as the terms were used there. So, and as we went through this, I was on a number of committees where the technical aspects were way over my head about how information is actually exchanged. Came to appreciate quite clearly the conflation and confusion of privacy with security and how the two are not the same. I came to appreciate how electronic data exchange standards were so important, how the standardization of data really mattered, how it was difficult to get systems to communicate with each other clearly and accurately to make sure that the information sent from point A actually arrived and was interpreted at point B the same way it was interpreted at the originating destination. Learn about concepts like data provenance and needing to make sure that you had some sort of audit trail for the data itself to understand its legitimacy or veracity, and also learn about metadata and all sorts of interesting concepts about how you can send information in an envelope and put data on the outside of the envelope, but not actually see the interior contents of the envelope, and how the metadata on the outside, the address, was very important to help you categorize, organize, find, and share information, and yet still maintain the privacy of the information contained within the envelope as you're porting information from place to place. And I also had a great appreciation for the divide, really the grand chasm between our aspirational hopes and the reality of where we were at the time, because you have a situation where conceptually It's desirable to have information in the hands of clinicians when patients come in seeking care. But the facilities, the hospitals and the clinicians have great angst about all of the penalties that go with privacy breaches, public notification, triple damages. It's a lot of difficulty when you have security or privacy breaches, and those issues are really substantial and difficult to overcome. And I think that those are even more important than the intentional siloing information for competitive advantage. But those issues continue to be a problem, particularly as we discuss even in elections or medical records or the financial sector about the danger and the peril of cyber attacks and ransomware and people having loss of access to their entire IT systems if people find a vulnerability and exploit it. So I share all of this just by way of background. I hope there's enough in there to give you some sense that in my prior life, I was exposed to these concepts and immersed myself in them. I have a great appreciation for the work that this community does. I also appreciate all too well that it can be probably as lonely a place to be as an IT professional as it is to be a public health commissioner in the middle of a pandemic. People are very critical, intolerant of information not being there. We know that a 3-second or a 2-second delay or a lag after each click is infuriating to the user and not tolerated well, and often expressed very clearly and in a pithy, sarcastic, perhaps not affirming way when they call IT for support. So I want to express a little bit of empathy with you, that I'm grateful for what you do and appreciate it. So let me try to bring this now a little bit more to public health, bring it to the state of Kentucky and where we are now, and I'll tie it into COVID-19 a bit. So this pandemic has obviously been an incredible challenge. It has required us to respond to a global infectious disease threat. So by using the term global intentionally, I mean it affects all human beings on the entire planet at the same time. It means that we are competing, all of us in humanity, for the same resources that have been highly consolidated in their supply chains into certain regions of the world. And when, in this instance, you had the Far East get hit first in China, and when China is one of the primary manufacturers for key and critical supplies, such as personal protective equipment, you can see very quickly how that becomes a problem, because you disrupt the very place that supplies the whole world for those supplies. So they're no longer producing them. And then you have the cascade of diminished resources out in the field, which are not big to begin with, because people do just-in-time supply chains now and keep very little inventory on hand. And then you see that cascade of everybody scouring for the same stuff when it's scarce, no more production occurring, and all the difficulties. Well, the same concepts that I just described for personal protective equipment apply in a variation for the data and the health information technology tools that we use. So when we started this, of course, the Kentucky Health Information Exchange had already been long at work, doing great work, supporting the sharing of information to support healthcare throughout this Commonwealth. But we had not all laboratories onboarded into KHI. And in addition to that, as we went along, and we built massive testing capacity for a single disease, by the way. So we have a number of labs who have grown up specifically for the purpose almost of providing COVID-19 testing. And we have other labs that have repurposed the vast majority or all of their laboratory capacity to testing for COVID-19, whereas before they probably had a more diversified portfolio. So in doing this, we had this massive need to escalate rapidly, onboard as many of these labs as possible, and receive their information, and then of course route it where it had to go, and then make sure that when it arrived where it needed to arrive, there were tools there to catch it and then present it to the human users in ways that they could interpret it and make use of it. This has been an incredible challenge because we're using, in many instances, legacy systems that have been around for quite a while. And there are handoffs between applications of varying sophistication, modernity, or antiquity, as the case may be. So the federal National Electronic Disease Surveillance System, NEDS, is the tool that is used by epidemiologists in 26 states and territories around the country, where they put in information, the epidemiologists, about test results and about patient data, and use that as a tool to do disease investigation, meaning to communicate with the individual with the infection, provide them information, and also inform public health actions. That system has been around for quite a long time. And I don't want to misrepresent this. I have in my head maybe the 1980s, but I could be wrong. I could be very wrong about that. So I should probably just take that back. But some of those technologies have been around for a long time and rely on an ecosystem of applications around it, obviously, to translate data from one app to the next app. And a real challenge that has been present during this is these systems were never designed to handle the volume of data they're handling now. And the resourcing that have been provided for these systems at the state level, and I imagine at the federal level, was spec'd out for a time when the volume going through them was much smaller. And we have increased by orders of magnitude the amount of data going into and out from these IT systems, and they are struggling under the volume and the strain. So we've had to add CPU, RAM, storage capacity to make sure that we could grow to be able to accommodate those needs. But a bigger challenge has been the software does not necessarily update as rapidly or easily as we would like. And then when you have, in this case, 26 states and territories using the same federal systems, but not doing it identically. So each one of those installations has its own uniqueness to it. It's very difficult to get clear, consistent, rapid, iterative improvements, because you often have to make sure, as you all know well, that the change one entity makes doesn't cause downstream adverse consequences for other users in the system. So this has been a real difficulty and a real challenge. I will say, I want to give a shout out to our technology folks here at the state of Kentucky. So the Kentucky Health Information Exchange staff, including Andrew, who's the leader there, in our data analytics shop. So we have Robert Putt, who'll be speaking to you here, and Mike Schutze, who I think is going to speak after me, and their colleagues have done a wonderful job helping to support this structure and make sure that I have visualization tools to be able to see some of the information as it flows through. And of course, the Department for Public Health has a dedicated team of epidemiologists, some of whom are medical informaticists, specifically working in that interface between health IT and epidemiology to try to help do the data checks and make sure that the information we're getting is in the right form and format and correct and flowing properly. And so this has been incredibly difficult as we've had to scale up and ramp up. We've had to try to find ways to invest in and increase the quantity of human talent that we have. We've needed more people, which is not always easy to get in the middle of it's kind of like being in a war and trying to recruit new soldiers in the middle of a war when all the soldiers are already gobbled up by others. And so there's just not tons of people sitting idly around in this domain to come and do this work, let alone at the state level. So those have been real challenges. Nonetheless, I am impressed, and notwithstanding the fact that there is public, frustration, understandably, because of the pandemic, or sometimes disappointment or upset, or questions that they would like to have answered that we can't always get an answer for. If you go to our KY COVID website and you look on the desktop dashboard, you can go and see updated on a daily basis the total number of cases, the breakdown by decade of life, gender breakdown. You can see incidence reports or incidence rates by county, and it shows you the population of the county. That as you click on the map, there's a lot of data there. And then when you look at the many spreadsheets and other presentations we give for data, you can look at representative information about how much disease is at a school or at a college or a university, in a long-term care facility. There's a whole raft of information that's already available. And it has been a challenge because it seems that no matter how much information we provide, someone has a new question or a novel way to ask the question, And the simple reality is we just cannot accommodate all of those requests. It's just not enough bandwidth. And quite frankly, we have to curate this data as best we're able to give the decision makers the information they need to decide, and also to be as transparent to the public as we possibly can, so they at least can have some access to the information we're using, and have confidence that the decisions we're making based on it are reasonable decisions when overlaid with the kind of professional expertise and talent we have across state government, particularly in the epidemiology community and public health, both state and local, as we work through this to navigate the pandemic. So I continue to be challenged, though, at how our hopes and our aspirations often have a gap or a chasm from where we would like to be and where we are, and the great difficulty connecting the two. It really is very challenging when you see visualization tools and information presented by others, and people can go and look on through the internet, say at a federal data site, and say, wow, that looks awesome. That is really cool. You can drill down county by county. But if you're someone in my position and you look and you say, well, yeah, it's a really cool implementation, but the data that is fed into it has certain limitations. And so you look and say, but you can reach the wrong conclusion by looking at that data if you don't have the right perspective and other data points that are not presented there. And I have no doubt, and we hear it here in Kentucky, when the state presents data, you have local health departments who not only have the data, but whose staff live and reside in the communities where they are reporting on. And so they now have not only information about a specific location or a specific group of people and numbers or data attached to that, they also know very personally, oh yeah, that's the place that's, on the corner of this street and that street where the stoplight is. And so they can put in their mind a much more personal and intimate overlay for that data. And so then they find deficiencies or concerns in the data set that are apparent to them, but would not possibly be apparent to someone like me who has not lived in that community. So it's that continuing messaging corridor of what are the strengths and weaknesses of the data, and trying to make sure people understand that those sorts of inconsistencies, while inevitable, don't undermine the incredible utility of these tools and the incredible value that we have using them. And that I think most of us who are doing this professionally as part of our full-time commitment understand these various limitations and account for them, and then work together to overcome it and navigate this smoothly and efficiently. So I want to tell you how proud I am of the state team, of the private partners we've worked with, of the laboratories who have worked with us so hard and well to get onboarded and try to report information quickly and accurately for us. We had a call recently with national leaders trying to consider how we could better integrate data and present even more data to the public so that it has access to it in a timely manner. Again, many of these things will take time to build. And of course, we always want it yesterday, but it's not the world we live in. So we're going to have to work within the resources we have and try to do this as we're able to. And we also look forward to a time when COVID is over. And then my great hope is that all these improvements we've made for COVID, when we take the strain of COVID away, that we will emerge with a stronger and a better information technology system and platform that will support us going forward. So let me do this now real quick. I'm gonna, because I said I could talk about COVID as much or as little as I want to. So for this audience, as I have just about 7 or 8 more minutes here, let me pivot from the technology piece with a very heartfelt and sincere thank you to all of you for what you do and for taking time to be here at this meeting over these next 2 days. I'm very grateful to you for what you do, and I wish you the best in your work, because we're all counting on you to help us get information to the right places so we can make the best possible decisions. But now let me give you a little update on COVID if I can. It's one of the unique benefits, hopefully, of having the health commissioner here with you. It's going to be a rough next couple weeks, or I'm sorry, couple months. Unfortunately, we have a tension between large numbers of people who are complying with the requirements to wear a mask and stay socially distanced, but we also have a substantial subset of society who has decided that they are not interested in participating in these public health measures that are so essential to minimize the spread of disease. The major problem that occurs then is if that subset of people who refuse to participate with the rest of society in these evidence-based interventions, if it's big enough, it undermines the value of all the work the others are doing enough that it requires more interventions. And that's where we find ourselves, that we had to take additional steps before Thanksgiving to keep people away from each other in additional ways in order to try to blunt what could have been an absolutely dire outcome after Thanksgiving. And so we will now see over the next week to 10 days probably what the effect ultimately is of the Thanksgiving holiday. And of course, now that it's still cold outside and we have Christmas and New Year's and other faith-based holidays over the weeks ahead, we have the challenge of people coming together, close together, things we normally celebrate and really look forward to all year, but things which are exactly the opposite of what you would want in a dangerous pandemic. And so the problem we face when people come together and the disease increases is not just these bigger numbers we announce and say that we have over 20,000 new cases in a week. It's that when you have larger and larger numbers of people who are sicker, that even if it's a smaller proportion, you have larger and larger numbers of people who get really sick and go in the hospital. And then, of course, a subset of them who die from the illness. And these are concepts hard for people to really understand. I think people can appreciate being frustrated sitting in an emergency department waiting room for 2 hours before you get taken back to a room to be seen, and they're frustrated they had to wait. People don't commonly, though, know what it would be like when you sit in the waiting room and there's nowhere for you to go, period. Or if you need to be admitted to the hospital and there's no intensive care unit bed left, or now they've already overflown from the normal ICU into regular hospital beds, which they are trying to do the best they can to use as ICU beds, and then there's no staff to take care of people. And so these are the challenges we find ourselves in. Unfortunately, there were technology difficulties with the press conference yesterday, but we had intended to show, and I think the governor did, how the state is divided into 10 regions for hospital preparedness. And in those 10 regions, 4 of them have ICU occupancy that's greater than 80%. And I don't know how many people here have ever been exposed to or studied queuing theory, but when you get, in this instance, when you get up over 80, 85% ICU occupancy, it gets really difficult because not all beds are created the same. They don't all have the same type of staff or qualifications. They don't have the same abilities. And then you have to start making more difficult decisions. So there are hospitals throughout the state who have postponed or canceled non-emergent surgeries and procedures for patients who would otherwise have had to stay in the hospital for a night or two after the procedure because they can't afford to have those beds tied up with those individuals. So now you start having already in Kentucky, the COVID patients crowding out people who have non-COVID needs. And that's obviously not good for the non-COVID patients. And it's not good for the COVID patients because the worse this gets, you start running out of space. And then you not only don't have room to take care of people with heart attacks and strokes and with aneurysms that need surgery and cancers that need removed, but then you also don't have places to care for folks who come in who are acutely ill or sick with COVID-19. And so we are heading down this path. We are very clearly heading down this path. We have had a tripling of patients in the ICU and in the hospital with a COVID diagnosis as their primary reason for being admitted. We've had a tripling from the beginning of September until the end of November. And right now, we're sort of holding steady, though some regions are getting hit much harder than others. And the question is, will the measures we took before Thanksgiving have been enough? Will public compliance have been enough to keep us from having a massive escalation like you hear in the news in Southern California, where they really are running out of beds again and having to make really hard decisions? So, and the vaccine, I'll just touch on very briefly. Of course, there's 2 vaccine candidates. One of them, the Pfizer product, will be reviewed by the FDA tomorrow. And if they issue an emergency use authorization, the processes are in place for it to be shipped out almost immediately by the federal government. And then the Moderna product is scheduled for a hearing next week, I believe. And if that goes well, that will be ready for shipment very immediately after that. And so we have to be very hopeful that these vaccines are going to help us with an exit strategy from this pandemic and protect the most vulnerable among us. I have to urge everybody to please put this in context. This is a disease that first affected our first known Kentuckian. Of course, there could have been people before this, but the first one we found and diagnosed with a test was March 6th. So we're looking at just about 10 months after the start of this in Kentucky, we have a vaccine. It's never been done before in human history. So this is incredible, the pace at which science has moved, and the hopeful effectiveness of the vaccine is really strikingly impressive. But just because we now have that, that's a miracle in itself, doesn't mean everybody can be at the front of the line, and there's not enough quantity for everybody to have it at the very beginning. So we need everybody to be patient, to understand we're working as best we can to deploy this as fast as possible. And we're going to have to target it initially to the people who are most vulnerable and or the people whose protection is so central to getting as much of society back to the activities it has to do as possible. And so we will work through that very thoughtfully. And I just thank you all for your own leadership in your communities and your jobs, even in your own families, just to help people pull together, be kind, be caring to each other. We're going to get through this, and we'll get through it together. And I do believe 2021 will be a much better year than 2020 has been. So it's been a privilege to be here. I hope you found a little bit of something of interest to you. Thank you so much. And Andrew, I hand it back to you. Enjoy the rest of the conference.
Thank you. Thank you very much, Dr. Stack, for being here. Next, I would like to introduce Mike Schutze, who is the Chief Analytics Officer for the Cabinet, serving in the Office of Health Data and Analytics. Mike?
Thank you, Andrew. And can you hear me okay?
Yes, sir.
Okay, so I will try to share my slides, and it's a privilege to follow the presentation that Dr. Stack just gave. So bear with me for just a minute. Do let me know, Andrew, if you can see the slides.
I can see them.
Perfect, thank you. So I'll start. I only have about 10 or 15 minutes to talk a little bit about my thoughts on K-High and some of the emerging work that we're doing using K-High data for analytics. And I will do my best to actually pick up on a couple of themes that Dr. Stack discussed. So every now and then you'll see me peeking at my other screen, so because I want to make sure I cover some of the things he highlighted. So I think what is really exciting personally in the analytics space in terms of K-High and health information exchanges in general is that we're moving into this new era of public health data beyond what's been in existence for some time now. It's standard sort of public health practice of having disease registries, these various surveillance programs that exist nationally on the state level and so forth. But I think the HIE and K-High in particular, I think stands out in bringing us into this new era of public health data. I think what is so exciting to me, analytically speaking, is being able to use a system like K-High to completely understand the full spectrum of the disease. And I think Dr. Stack just made the point, we're sort of leveraging this opportunity, if you will, of COVID to really speed up the development of K-High, adding enhancements, working with all of you, building those relationships. But I think it'll be a long lasting impact of not just COVID today, but all other diseases going forward. So I think that's exciting. The other thing that's exciting about working with Andrew and his team is that KHI not only captures the clinical information, but what's really also important is to understand the patient characteristics, the demographics, comorbidities are of course clinical, and socioeconomic values. I know you all understand the importance, and there's currently an emphasis, and there will be going forward, on race and ethnicity and so forth, and equality and equity. I think that for too long has relied on sort of insurance program enrollment, and that data for good reasons has been incomplete. You know, perhaps you could argue that race and ethnicity for ethical and moral reasons should not be part of that process. And I think you are in a position as clinicians and hospital administrators to actually collect much more complete data on patient characteristics that are so important to understanding the sort of the clinical progression of disease. So I think that is very exciting from a health services research perspective, which is where I come from. System transparency is perhaps the next thing that's important to all of us here in Kentucky and beyond, because in the health services research arena, we've, for some years now, about a decade or so, we've worked very closely on APCDs, and they're still emerging to some extent, but APCDs, all payer claims databases, have provided that system transparency in terms of pricing for health services. How do patients move through the healthcare ecosystem, if you will, but there's no clinical information or very little clinical information. I think a KHI system and other HIEs really provide that clinical system transparency. You can truly begin to understand the full spectrum of the disease and see how patients move through the system post-discharge. What treatments do they get? Does that, you know, more or less, and I'm not a clinician, address their clinical situation at that point? Are there reoccurring? Are there long-term illnesses? Are there chronic illnesses? How do they interact with the healthcare system, and are some ways better than others? So I'm looking forward to this period of having this level of system transparency with all the appropriate privacy protections, but just to understand the healthcare system as a whole. It's become more diverse. There's more providers than there've ever been. Lots of innovation in the healthcare space. So HIEs certainly provide a lens into that system and how patients flow through it. So it's an exciting time, analytically speaking. I want to touch on, just as perhaps as an example for you all, on how we have started to use KHI data for some analysis related to COVID. And we're excited about this opportunity. A year ago, that was not something we were able to do. And through Robert's and Andrew's leadership, we now have the opportunity to use KHI data for analysis in state government. So we kind of took that opportunity at the beginning of the outbreak, and we brought a team together to look at this data and understand it better, and then use the information in KHI to at least develop some modeling projects for predicting active hospitalizations. So this particular project I'm going to talk about to you is a partnership between CHFS and the University of Louisville, School of Public Health. Dr. Saeed Karimi has taken the lead there at the School of Public Health. He's a healthcare economist, and we've worked very closely with him, and he's one of the first people in academia and the research community to use KHI data, along with some other colleagues there at U of L and certainly others at UK. All of this information is public. I have about 13 slides total, a lot of pictures. I'm going to go through them relatively quickly because I only have 10 minutes, but the information is publicly available. Dr. Stack has reviewed it. He felt it was very important to him. He thought it was meaningful, helps him understand the disease much better in terms of hospital utilization. So here's the link. I'll share the slides with Andrew after, so you can distribute them to participants or folks on the call today. So first, simple graph, but it tells a good story. This is KHI data. Okay, this is hospitalizations of confirmed COVID cases. There's 4 lines here. Some are hard to see. You sort of have this is last updated last week on the 5th Monday. We do this every Monday. We aggregate the data and look at the current trends. We do look at the data as it is reported, and then we do correct for some incompletion in the data, and that was new to me. I'm very familiar with claims and encounters and sort of the incompleteness of that data, or the lag in the data, if you will, that still holds true even for HIE data, which is interesting because in most cases, HIEs, you talk about quote unquote real-time data. So there's still information that's manipulated even after a patient is discharged for good reason, but it's something that researchers need to be aware of so they know the day they look at the data, it might be incomplete because there's still work done on those records even after the patient is discharged. And that sort of was the first lesson learned. So here you see the trend. We put in some vertical lines just to point out some different time points. If you look at the red line, it was the sort of the dotted line. It's hard to see. It's the report on 1205 that we created, and then we correct upwards for what we know now is sort of the anticipated incompleteness. So in Kentucky as a whole, you can see a dramatic increase in active COVID hospitalizations since Labor Day, and we're somewhere around above 1,500 active hospitalizations today in the KHI system, reported in that system. So that's good information to have just by itself. Dr. Stack sort of highlighted the SNEED, or how the state is divided into these 10 regions. And for modeling purposes, we're sort of been observing and monitoring the systems. Each one of these regions is a system, if you will. And we recently did a study with Dr. Karimi on regions 2, 3, and 4, 2 being the dark gray, sort of east of Kentucky Lake region, and then moving further east into Warren County, centered on Bowling Green, and then certainly Jefferson and region 3 and Louisville. And so we've developed some modeling. This is the data that you have in KHI. Interesting trends, very different by region, which is a great lesson that we learned too by looking at this data. So orange, you see region 3, Louisville, greater Louisville, so somewhat undulating line there with the recent increase since late September, October. Dark gray region 2, you saw an early spike there in April, and then again, that steep increase since late September, early October. And then region 4 in the sort of lighter gray line is very interesting. They've had almost no break at all in between. They've just been gradually increasing since the beginning of the outbreak. It's almost linear in its way, just steadily increasing over time. So these are good things to know about the pandemic, how it sort of works out in different ways in different regions and different hospital systems. So let me check my time. I got a couple of minutes, so I'll pick up this pace a little bit. This is sort of the math behind it. We're looking at active hospitalization data reported to KI for each one of those 3 regions. And then we try to model, adapt our model to fit that line, the observed line. It's hard to see here. You can go to the paper online. There's sort of a solid line in there. That's the observed rate, the cases actually reported to KI. Then we develop our model, and we need to refine that model, right? And we want to get ever closer to the observed line in the middle. And there's a second line in there that's hard to see. That's the median of the simulations that we run. And that median almost overlaps with the observed rate. At this point, we think, okay, our model, computer model, understands how the outbreak works. So we feel comfortable now, given what we know today, that we can project the future, if you will. So this is the work we did. This is the actual data reported to KHI and the simulations. Then we do a lot of other related research, both empirical research, but also literature reviews, where we have to make some assumptions. That's sort of the hard part about predicting the future. We cannot predict the future, but we try to come up with a very good estimate based on what we know today. So again, this is all in the paper. We looked at all different types of things that can impact how COVID spreads. And that's what we built into the model. And I'll let you read that on your own time, but it's well-informed, it's science, it's published literature, so it's very good information. We feel very comfortable about it. So then what do we do? There's a dotted line, same 3 graphs if you've seen before. Everything right of the dotted line is the projection. And this particular example that I picked out, if you read the header, is the assumption here is we have to model this using different assumptions. This is sort of assumptions number 1 is status quo. Nothing changes. If nothing else changes, there's no compliance, everything goes on the way it's been sort of going to date, this is where we would expect you to be by January 15th. And that's what Dr. Stack said too. He sort of issued that warning, the next 2 months will be very, very difficult. So we're projecting through the middle of the new year, January. So these are the projections, giving that nothing else will change. Okay, those projections are pretty dire. Let me look at this more closely so we can see it easier. So this is region 2, just east of Kentucky Lake. The dark red line there that you can see, well, first of all, let me start with the black line. The black line is the observed number of active hospitalizations in K-high, then you have the dotted line, and then you have a bunch of different colored lines. The dark red line is the status quo projection. If nothing else changes, if we go on as before, this is where we would expect to be in January 15th. And that's what Dr. Stack was just talking about. If it's kind of hard to see, and I don't know if you can see my pointer, but in January 15th, we're projecting somewhere north of 850 hospitalizations due to COVID in region 2. Well, for that particular region, that would exceed capacity, total bed capacity. So we're not even talking about beds actually available to COVID patients. This is total bed capacity, every single bed in that system. And I know that number can move up or down based on different things people can do in the hospital system. But by and large, that would control every single bed in that system. Now, none of us expect that there's absolutely no compliance, and we already have data that the recent measures had a great effect. But let's even go to low compliance, a lower level of compliance. That still gets to about somewhat north of 400 COVID patients by the middle of next month. That is still half of that system. And again, not all of those beds are actually technically available to COVID patients. So these are the types of things. We don't know which one of these will finally sort of work out and where are we closest, but it's something that people need to know to make decisions, right? So region 2, based on our modeling, would say, well, we really need to think and prepare for what might come, because it's certainly going to stress that system. Here's region 3. Different story. You have to look at it by these regions. Again, no compliance, somewhere close to 1,700 cases by the middle of next month. But that system has, give or take, about 3,500 beds in operation. Again, not all beds are available to COVID patients for different reasons, but something to think about. Even at lower compliance, it's still a significant number of cases. Then we go to region 4, same idea. I'll let you look at that on your own time because I know I'm running out of time. And here's my sort of last slide for today. And again, I appreciate the opportunity to present it. We are working very closely with K-High and through Andrew, through K-High with you on doing a lot of data quality analysis, since this is one of the first times, and this is true not only in Kentucky, but nationally, that HIE data is available for analysis and research. You learn a lot from that experience. We need to understand how the data is collected. We already are aware of a number of differences and challenges, ICU reporting being one of them. That's not done consistently through hospital systems. So each hospital system might report an ICU state differently than another system. So that's something we have to learn about. Coding practices, standardization, common data models. Those are all the types of things we need to work on in the next 6 to 12 months and the years to come. There are some emerging national data models that are more prevalent than others, but there's no one system yet that has proven to be the sort of gold standard, if you will. So that's certainly something we're working on. National effort I want to make you aware of that I'm personally involved in too, if you aren't aware of it already. I work closely with the Patient-Centered Outcomes Research Institute and the group that they've convened. They receive funding from the Office of the Secretary, the HHS, and they have what they call the Patient-Centered Outcomes Research Trust Fund. And we recently had several meetings late fall thinking about how can we use, and they were appropriated funding for the next 10 years, which is sort of, surprising really on that level of organization at the federal government, that they've been granted this funding for the next decade. And they are thinking very deeply about how can we use HIEs, and what I highlighted here is to build the data capacity for comparative clinical effectiveness research. And there's been a lot of thought leaders, wonderful people, some of you may be involved as well, really critically thinking about standardization, coding practices, common data models for HIEs, because I think you are truly part of something that will bring us into this new era of public health, and it's incredibly exciting. I think we can learn so much from the data that you all collect and enter into the system. I think it will improve patient care, it will improve outcomes, and it will do so much for society if we can all work very closely together using these just incredible resources that we have at hand. So with that, Andrew, I hope that met your needs. I've enjoyed talking to you all, and feel free to
Absolutely.
contact me with questions. Thank you so much.
Thank you, Mike. Thank you for sharing your expertise and for displaying some of the ways that you guys are taking the KHI data and turning it into something tangible for clinicians. So appreciate your insight into this. Okay, we're going to end the session now. If you will make your way into the next one, we have lined up a great group of speakers for a panel discussion. And so after we end this, just enter into the next room. Thank you all.